Good morning, everyone. Welcome to Medicine Grand Rounds. Before I introduce our speaker this morning, I just wanted to call your attention to our end of the year schedule. So we will have Grand Rounds next week. Dr. Josh Keller with Rheumatology Associates, one of our former internal medicine residents, will be presenting. But we'll then take a hiatus for the last week of June and I believe the first week of July. And then our summer series will start after that. So Heidi will be sending out notifications, but I just wanted to make sure you knew that there would be an interruption in Grand Rounds for a couple of weeks due to the transition of our new interns and departure of our senior residents, et cetera, just that whole transition period. So this morning, it gives me great pleasure to introduce our speaker, Angela LeClerc from the Department of Critical Care. Many of you know Ms. LeClerc from Maine Medical Center. In case you didn't know her background, she started out getting a BS in nursing at the University of Southern Maine and then completed the physician assistant program at the University of New England and has worked as a PA for 20-something years, I believe, or close to that. She most recently has been working in our critical care department at Maine Medical Center since 2014, where she serves as the program manager and lead APP. She has held a number of leadership roles in the institution and has also served as the president of the Physician Assistants in Critical Care, which is part of their national organization. She's been a Mite Scholar and is an Academy Fellow as of January of this year. She's also an adjunct clinical professor at the University of New England PA program. So Angie, thank you so much for being with us today and sharing your knowledge about midodrine.
Great, thanks so much. Thank you all for having me. I'm really excited to be here this morning. If you have any questions, before I forget, you're free to put them in the chat box and I will probably look at that when we're finished, or you're more than welcome to unmute yourself and interrupt me. What we're going to be talking about today is midodrine in acute care, and I actually gave Grand Rounds on this topic about 3 years ago. So I've modified this presentation, although there is going to be some critical care data that we're going to review. And when I repeated my literature review, I was excited to see that there were a couple of new studies that are actually really relevant to hospital medicine. I don't have any disclosures. And our objectives today are going to be to review the pharmacology of midodrine, describe current trends with off-label use of midodrine in the acute care setting, analyze the current data supporting the use of midodrine in septic shock, and really it should be resolving septic shock, and discuss weaning of midodrine versus continuation at discharge. And I'm assuming many of you receive patients from the ICU on midodrine. Perhaps you prescribe it to your inpatients for a variety of reasons. And we're going to review what the starting dose should be, when we should wean, and try to discuss whether patients should be discharged on midodrine. Midodrine actually is a little bit of an interesting story. It was originally approved by the FDA to treat symptomatic orthostatic hypotension in 1996. And the drug was approved under the FDA's accelerated approval process as an orphan drug. And this allowed quicker market access to a medication for serious or life-threatening illness based on surrogate endpoints, with the understanding that the manufacturer will conduct more rigorous studies to show the product's efficacy. However, midodrine's original manufacturer, which is Shire, never presented acceptable confirmatory efficacy trials to the FDA. Although it did submit 2 trials, they were both rejected by the agency for lack of rigor. And then in 2010, so almost 15 years later, the FDA threatened to withdraw midodrine from the market because of the lack of confirmatory efficacy trials. And this would have been the first withdrawal of a medication granted accelerated approval. When patients and physicians heard about the potential withdrawal of midodrine from the market, they wrote and talked to the media about worries that midodrine was going to be removed and how much it had changed the lives of these patients and what a safety issue it would be if it was removed. And at that time, you can actually Google it, there's an article in the New York Times in 2010 about it. The FDA backed down and reached an agreement with Shire in 2012 to have the company conduct trials that may satisfy the agency's efficacy. And there's been a couple of very small trials put out following that. So some other trade names for midodrine are proamantine, amantine, Inramed, Gutron, which I've never heard of, and Bromox. Midodrine is an inactive prodrug that is deglycinated through enzymatic hydrolysis to an active metabolite called desglamidodrine. It's an alpha-1 adrenergic agonist that produces both arterial and venous vasoconstriction. One of the oldest studies that we have on midodrine was published in Neurology in 1998. They took 25 patients with neurogenic orthostatic hypotension, and they were randomized to placebo or midodrine at 2.5 milligrams, 5 milligrams, or 20 milligrams. And this was a 4-way complete crossover study. Dose responses were recorded and analyzed, as well as blood levels of midodrine and desglamidodrine. So this first table, we're looking at those 4 different groups or arms of the trial. And on the left-hand side, we can see the hours, and I've highlighted the 1-hour time mark, where at the placebo, patients' blood pressures were approximately 95 systolically. And as you work your way from 2.5 to 10 to 20, we can see that there's a dose-related response with increasing blood pressure with the higher doses. And the 10 milligrams group was approximately 120 for the systolic blood pressure, which is actually a pretty good target for these patients with orthostatic hypotension. So the goal was to be approximately 110 to 120 with standing. And then we can see as time goes on, and we look down on the left-hand side as the hours are ticking by, at approximately hour 4 is when we start to see after that, that the blood pressure starts to drop more. So at hour 4, it's approximately 105 for systolic blood pressure, give or take about 9 points. And then at hour 5, it's about 94. If we look at the mean increases in blood pressure at 1 hour at each of these doses, placebo gives you about 5 points in your systolic blood pressure. 2.5 milligrams of midodrine gives you about 7.5. 10 milligrams gives you about 30, and 20 milligrams gives you about 43. So it looks like the lowest effective dose here is midodrine 10 milligrams, which I think is typically what we are all prescribing as a starting dose. There are 2 graphs on this slide, and the graph on the left represents supine systolic blood pressure, with each line on the graph representing the different doses of midodrine. The lowest line is placebo, and then as we work our way up these lines with the triangles, it's 2.5, and then the squares, it's 10 milligrams, and the circles are 20 milligrams. Here, you can see that the 10 milligram doses, which are the squares, are probably the lowest effective dose with a supine blood pressure of approximately 160. We really wouldn't want to go much higher than that, because when we look at the standing systolic blood pressure, which is the graph on the right, which I would note that at the top of this graph, the highest blood pressure is 140, so it's different than the one on the left. The goal is normotension. And we can see here where that blue arrow is, that's 110 to 120. And again, the squares, the 10 milligram dosing is where we want to be. These 2 graphs are when they measure the plasma levels of midodrine and desglamidodrine. The peak concentration of desglamidodrine, which is the active metabolite, is at approximately 1 to 2 hours. And we can see that here in this graph between the 2 red lines. And at approximately hour 4, we've reached a half-life. And you can see on the left with the midodrine plasma concentrations, it's a much quicker drop. But really what we want is the desglamidodrine. So one thing that I do want to comment on here as I was going through this presentation, I was wondering why we don't prescribe midodrine at Q6 hours instead of Q8 hours. So I did a quick search, and there actually was a recent publication. The most recent literature on midodrine is really coming out of the Mayo Clinic for acute care uses. And they actually just published an article this year suggesting that the dosing frequency of midodrine may need to be increased to Q6 hours to optimize its pharmacokinetic profile, particularly in some of these trials. And we'll talk about the different dosing strategies in these trials in a minute. So to summarize the pharmacokinetics of midodrine, the serum levels peak at 1 to 2 hours. The half-life is 3 to 4 hours. And 80% of desglamidodrine is renally excreted. So that's why we start with lower doses. And you can probably decrease the frequency in those patients as well. It is dialyzable. It does not cross the blood-brain barrier. And I have a little caveat there, a little asterisk, because it actually isn't clear as to what desglamidodrine does in the blood-brain barrier that is injured. We do prescribe midodrine to a lot of our neurocritical care patients, and I'm certain that their blood-brain barrier is not completely intact, but there are no studies looking at this. And the oral bioavailability is 93%. So summarizing the dose response for midodrine, we saw that the systolic blood pressure increases in a dose-dependent manner. And looking at two different studies, one in neurology and one in JAMA in the 1990s, we can expect an increase in systolic blood pressure of approximately 20 to 35 millimeters of mercury with 10 milligrams of midodrine. Adverse effects include supine hypertension. This is the most serious adverse effect and can be reversed with phentolamine, which is an alpha antagonist. Urinary retention, bradycardia due to the parasympathetic reflex with the hypertension, shivering, paresthesias, pruritus. And then this year I came across just a case report of a patient with chronic kidney disease who was on midodrine and had myoclonus that was attributed to the midodrine and resolved when the midodrine was stopped. So I think in acute care, we're most aware of all the off-label uses of midodrine. Hepatorenal syndrome and dialysis-induced hypotension are pretty common. For the remainder of our time, though, we're going to be focusing on the more acute care patients that we may run into on our services. Spinal cord injury, carotid stenting, advanced cardiac failure, shock due to myocardial stenting after revascularization, septic shock, which really most of the studies are looking at resolving septic shock, and postoperative surgical ICU patients, which we talked just a little bit about. So I have a case that was emailed to me by one of the hospitalists here. So this is a patient that was at Maine Medical Center. We're going to kind of present the case, and then we're going to talk a little bit more about some data, and then we're going to come back to the case and look at it in more detail. So there's a 64-year-old female with a past medical history of severe COPD, ongoing tobacco dependence, chronic opioid and benzodiazepine use, hypothyroid, bipolar disorder, depression, and a history of suicidal ideation. There's a lot of things to say here, but we're just going to focus on the case presentation and the midodrine piece. She was in out-of-hospital cardiac arrest. It was PEA and likely secondary to pneumonia and an acute exacerbation of her COPD. She underwent targeted temperature management. She was rewarmed and was following commands. Her course was complicated by acute cystitis, volume overload, and a tachyarrhythmia. She had an echo that showed a right ventricular systolic pressure of 41. She had severe tricuspid regurgitation and an ejection fraction of 45%. And at the time, she was waiting for a right and left heart cath. So some details of her case: she was extubated on hospital day 2, which is great. However, she had remained on low dose norepinephrine after being extubated and having her sedation weaned. She had been on quite a bit. I think she was up to 0.2, but was down to like 0.03 after extubation. And they started her on midodrine to try to wean her off the norepi, which worked very well. They put her on 20 milligrams Q8, and then she was titrated up to 30 milligrams Q8. And then eventually, I think it was hospital day 5 or 6, she ended up on carvedilol. She got 1 dose of carvedilol due to a narrow complex tachyarrhythmia. Cardiology was involved. They thought it was AVNRT. And unfortunately, she rearrested on the floor, was not resuscitated. She was a DNR DNI at the time. And so prior to looking at these details, we are going to review some evidence and then revisit this case and look at the midodrine prescription. So why are we using midodrine in acute care? We should note that approximately 1/4 of patients in the ICU are treated with IV vasopressors. And since midodrine can be used to spare vasopressors, it can lead to decreased central line infections, decreased delirium, decreased ICU and hospital length of stay, decreased hospital and ICU acquired infections, and decreased adverse effects of vasopressors, which we know are peripheral and visceral ischemia, direct cardiac toxicity, and direct cardiac toxicity with prolonged use. Patients on vasopressors also are less mobile, and that can lead to longer durations of stay. So this study was in 2018 when they looked at the prescription of midodrine in the ICU from 2011 to 2016. This was performed at the Mayo Clinic in Rochester, and they looked at medical and surgical ICU patients. And you can see this clear trend from 2011, where they found that they prescribed midodrine in the ICU to 50 patients, to 2016, where they prescribed it to 350 patients. And they have a 158 adult ICU bed capacity there. You can see there was probably about a 50-50 split here between the SICU and MICU patients for prescription. And they had a really good sample, about 1,100 patients. Their prescribing practice was midodrine 5 to 30 milligrams every 8 hours. And it looks like the cardiovascular surgery ICU service, as well as the medical ICU service, were the most common prescribers of midodrine in the ICU. They also looked at 2 patterns of midodrine use. The first one was using it as an oral agent to allow weaning of vasopressors, which is where we see a lot of the studies. But the second group of patients was as an oral agent that was introduced early prior to vasopressin initiation. So I just wanted to point out that they did use this prior to vasopressor initiation. So in the patients that were not on IV vasopressors at baseline, only 10% were on pressors after 24 hours of midodrine. In the second group, the patients that were on IV vasopressors at baseline, only 50% were on pressors after 24 hours of midodrine. Bradycardia, which was asymptomatic, was the most common serious adverse event. So if we look a little more closely at some of these special populations, I will go through this pretty quickly. Spinal cord injured patients, there is some literature out there on acute and chronic spinal cord injury and some ongoing studies in using midodrine to treat their hypotension. But mostly there's just one case report of a patient who was immediately post-op that got 10 milligrams TID to wean off norepinephrine as an inpatient. Another special population would be carotid stent patients who undergo the stenting procedure, and with manipulation of the carotid bulb end up hypotensive and bradycardic postoperatively. And there's a case series of patients who got midodrine as a treatment of the hypotension associated with carotid stenting. Obviously, like a rate limiting factor might be the bradycardia, but these patients they looked at retrospectively, they found that there were 4 patients that got midodrine and no dopamine out of this series of 15 patients, and the patients that got midodrine never ended up going to the ICU. So clearly this is a cost savings. Another special population would be the cardiac ICU. And this is a 3-case series of patients who were successfully treated. Their hypotension was successfully treated with midodrine. They were all on dopamine initially. They all had myocardial stunning, which was defined as reversible decrease in contractile function of the myocardium. Often that results in hypotension following ischemic stress, which we actually see quite frequently. And you probably encounter some of these patients on the hospital medicine service once they're discharged out of the ICU. All 3 patients had revascularization that was successful. None of them had overt heart failure. They were all prescribed 10 milligrams TID of midodrine and were weaned off their dopamine. And they all actually, I'm going to flip through them, they all were discharged home on midodrine. And then they were all weaned off the midodrine after a period of 1 week. So that's pretty much what there is in the literature about acute treatment in the setting of myocardial infarction. These patients, this study is actually pretty interesting with advanced heart failure. We all know that beta blockers and hormonal blockers like ACEs and ARBs are indicated for decreasing mortality in patients with systolic heart failure. They're kind of cornerstone of therapy for those patients. And this study looked at 10 patients with ejection fractions of less than 35%. They were prescribed 5 milligrams of midodrine Q6 and then increased to 10 milligrams Q6 in an effort to try to get them on higher doses or actually get them on beta blockers or ACEs or ARBs. The 10 patients, like I said, 10 of them had systolic function, and half of those patients had biventricular failure. And if we look here, they looked at some outcomes. So they have baseline, which was not with midodrine, and then 6 months, which was with midodrine, where their New York Heart Association classification decreased. And if you look at the ACE and ARB use, where these little parentheses are, we went from 50% of patients being on ACE or ARB to 90%, more optimization of their ACE and ARB dosing from 20 to 58%. And then again, with the beta blockers, 80 to 100%, and with diuretics, 70 to 90%. So they were able to increase all of these cornerstone therapies. And in the end, their ejection fraction went from about 24 for a mean to 32 for a mean. So these medications were able to help these patients have optimized therapy. So there's just not a lot of really good literature on these patients with the spinal cord injury, carotid stenting, and cardiac with the stunned myocardium or the advanced heart failure. They're all very small and retrospective. So if we return to our case, I think this is a good time to look at this case, and she was a cardiac arrest, and we just reviewed a little bit of what's out there for cardiac literature. If you recall, she was an out-of-hospital cardiac arrest. She was PEA. She woke up, was following commands after targeted temperature management, and she was extubated on hospital day 2 on low-dose norepi, and midodrine was used to try to get her off her norepinephrine. So I was able to go through the vital signs in the chart, and on the x-axis of this graph are the vital sign occurrences from hospital day 3 to 8. So each number on the x-axis is a vital sign point. On the y-axis, there is the mean arterial pressure on the blue line, and then the heart rate on the orange line. And then at the top, you see a star that is to indicate that there's some compressed data points, because on hospital day 3, when this starts, the patient was actually in the ICU. So I had a lot more frequent data points. And then obviously, as they went to the floor, their vital signs were less frequent. So we can see here where it says NE off, that's the norepi off at the top. And at the bottom, you can see that M20 is midodrine 20 milligrams Q8 prescription, and M30 is midodrine 30 milligrams Q8 prescription. And each one of these arrows indicates when the midodrine was given per prescription. Towards the end, around 38 to 39, 40 is when the patient had a tachyarrhythmia and some severe hypertension and was given 1 dose of carvedilol. And around 42 is when she was found unresponsive and had passed away. And I think what I really wanted to show on this graph was this is the goal, the red dotted line that's going across for the mean arterial blood pressure, that's 65. And this patient was well above that MAC goal much of the time that she was being prescribed midodrine. It's possible that some of the hypertension that she was experiencing intermittently was causing this tachyarrhythmia. It's possible that it had nothing to do with it. But this is, we'll look at a study in a little bit that talks about weaning midodrine in the hospital setting or continuing it. And I think it's really important that we are always revisiting whether the patient needs to be on midodrine or not. So if we move on to another case that is more of a sepsis related case, this was a case that I had. We had a 67-year-old female who was admitted with 2-day history of generalized malaise and 24 hours of fever, chills, and back pain. Her UA was grossly positive. She had a high fever. Her MAP was 60. Her heart rate was 95. She was sitting very well on room air. Respiratory rate was 22. She was alert and oriented, but she was rigorous in bed, and she had right-sided costovertebral angle tenderness. She had gotten a couple liters of IV fluids, which was approximately 30 cc's per kilo for her, and her MAP was still about 60. So we had started her on norepinephrine and transferred her to the ICU. So she clearly has pyelonephritis and was complicated by sepsis, septic shock. So we're going to get back to her case to see what happened in a few minutes. There's not a lot of data out there about midodrine use and septic shock. This is an earlier feasibility, utility, and safety study on midodrine. They had 2 arms that looked at patients with pressors and patients with pressors and midodrine. And they wanted to, their primary outcomes was to look at the duration of IV vasopressor use and then also ICU length of stay. And because this was retrospective, there was no protocol for administration, dosing, or tapering of midodrine. So their standard initiating dose was 10 milligrams Q8 to the max dose of 40 milligrams Q8. These patients were had their midodrine discontinued in the hospital. Actually, most of them did, 117 out of 135, and the average duration of prescription was approximately 6 days. They had 18 patients who were just discharged home on midodrine. And this is just to show that the patients were well matched in each group. Their source of sepsis was mainly pulmonary and urinary, which is probably mostly what we all see. And what they found was the IV vasopressor duration was decreased by 24% in patients that had midodrine added to their vasopressors, and their length of stay was decreased by approximately 20%. And this didn't reach statistical significance, but the creatinine was lower in the midodrine group as well. This is an abstract that was published in 2017 that looked at patients with IV vasopressors, the same idea, and then IV vasopressors plus midodrine. They found that there was a longer vasopressor duration in patients with midodrine. It was not shown to reduce the duration of IV vasopressors. It was not shown to reduce hospital length of stay or ICU length of stay in patients with shock. And all these patients have been receiving at least 7 days of IV vasopressors. I mean, this doesn't really mean a whole lot to me. It was a single center observational retrospective study. it was a very subjective determination about whether patients were going to be administered Midodrine. There was no protocol. So I'm not sure that we can really hang our hat on anything here. So if we review what we've looked at so far for resolving septic shock, we have one retrospective study and then one abstract with retrospective mixed shock. Not very helpful. But there's more. There's more about weaning vasopressors in the ICU. This is another one that was a single center retrospective observational study. Adult patients, obviously. Their primary outcome, again, was the time to IV vasopressor discontinuation after Midodrine. But they also looked at ICU discharge, ICU length of stay, and ICU readmissions, which is important. We don't want our patients going to hospital medicine, then bouncing back to the ICU. So if we look at their outcomes, the time on IV vasopressors prior to Midodrine initiation. So it looks like they were on pressors for about 1.5 days, and then they were prescribed Midodrine. The time to ICU discharge after IV vasopressor discontinuation was double in the control group. And hospital length of stay in the Midodrine group was 12, and the control group was 9. In hospital mortality was actually lower in the Midodrine group. So they used a dose range of 10 milligrams TID. I mean, a dose of 10 milligrams TID, not a range. And their range was 2.5 to 10 milligrams, and they administered that 2 to 6 times daily. The median duration was 4.4 days, and they had 6 patients who experienced hypertension and 12 patients who experienced bradycardia. So there were multiple limitations to this study as well. And then you're like, oh gosh, I haven't presented any real good evidence to support the use of Midodrine in any kind of sepsis, really, or early sepsis. One of the studies that we were waiting for when I gave the grand rounds 3 years ago was this MIDAS trial. And this was published in 2020 in Intensive Care Med. And the bottom line is they looked at, this graph shows vasopressor discontinuation rate that they were looking at. They had excluded a bunch of patients, patients who did not require vasopressors for greater than 24 hours, patients who had multiple vasopressors, chronic kidney disease, hepatic failure, severe organic heart disease, hypovolemic shock or shock secondary to adrenal insufficiency, that's appropriate, and the usual like palliative care and CMO patients. And what this showed was time hours after randomization and then vasopressor discontinuation on the y-axis was that there was no difference between placebo and Midodrine. But one of the big problems with this study and with some of the other studies that we look at is that this was a fixed dose of Midodrine at 20 milligrams Q8. And so we'll kind of get back to this non-titratable weakness in these studies. This study was published in Critical Care Exploration and this year, actually in May. I think I might have sent this to a couple of the hospitalists. It's a pilot that was performed at the Mayo Clinic in Rochester, and they partnered up with the Cleveland Clinic in Abu Dhabi. Placebo-controlled, double-blinded, randomized clinical trial. They looked at adult patients within 24 hours of meeting sepsis definition, which was the MAP of less than 70, despite timely antibiotics and IV fluid bolus at the 30 cc's per kilo. And they only had a few patients, so 17 and 15, and the 17 patients that were in the treatment arm got 3 doses of 10 milligrams of Midodrine. So that was at Q8. This is a timeline of their process or methods. So they had recognition of sepsis. They were given empiric antibiotics and IV fluids. They were consented and randomized. Their first dose of PO Midodrine or placebo was given approximately 13 hours into the study. And they got their second and third doses after that. And the bottom line is they didn't really see any difference in their primary and secondary outcomes. Again, only 15 patients in the placebo group and 17 in the Midodrine group. So if we return to our case, our patient with pyelonephritis and septic shock. She ended up getting admitted to the ICU. She got put on norepinephrine for about 5 hours. She had definitive treatment of her pyelonephritis. She ended up going and getting a large stone removed, and I think she got a percutaneous nephrostomy tube. And she ended up being hemodynamically stable and moved to the floor in less than 20 hours, I think. She was discharged home and did very well. She did not receive any midodrine. Her lactate at the time of admission, I left off the first presentation of this patient, was 2.4. And I want to think about this patient in terms of, is she possibly a patient who is a candidate for early midodrine instead of using pressors? Maybe, maybe not. I don't have the answer to that. So this is another newish study that was published in Critical Care Medicine in 2019. This looked at continuation of newly initiated midodrine therapy after intensive care and hospital discharge. So it's a single center retrospective study. They looked at patients in the ICU from January of 2011 to October of 2016. And these were ICU patients admitted to the ICU and receiving midodrine for hypotension, and they had to survive to ICU discharge. They were able to evaluate approximately 1,000 patients. And we can see here that the makeup of the patients is mostly cardiovascular cardiovascular surgery ICU, actually, where there's approximately 300 patients that were prescribed midodrine. Although if you look below that first red box on the left, a large portion of these patients had sepsis. ICU vasopressors were ongoing at the time of midodrine initiation in 58% of patients, so in over half of the patients. And the duration of midodrine was approximately 14 days in those that were continued on it following the ICU discharge. Those that were continued on midodrine after ICU discharge had a decreased ICU length of stay. And then this was the 1-year survival figure after hospital discharge in those patients that were continued on newly initiated oral midodrine at hospital discharge compared to those whom midodrine was stopped prior to hospital discharge. So the top line is the discontinued, and the darker bottom line is the continued. And the patients that had the midodrine discontinued, like I just stated, you can see had improved survival at 12 months. Interestingly, what they also found in this study was that 50% of the patients that were discharged on midodrine were also prescribed an antihypertensive. I'm not sure how many of these patients fell into that category of trying to optimize cornerstone therapy for advanced heart failure, but I can't imagine that 50% of them were. And then they also looked at concomitant medication prescription at the time of discharge. And I would probably focus more on the light gray here, because the light gray is discharged from the hospital on midodrine, which was 311 patients. And 50% of those 300 patients were discharged on any antihypertensive. So it looks like 24% were beta blocker, 1% was an ACE or ARB, 33% was a diuretic, and 2% calcium channel blocker, and then 1% other. So it would be interesting to kind of look and see if that was intentional or not. And I think what I'm going to try to do right now is switch over to wrap things up and give some time for questions. So the general concerns with midodrine are the ability to absorb oral agents with potential GI tract edema or intestinal vasoconstriction. So those patients probably aren't candidates for midodrine as a pressor. I worry a lot about the heterogeneity of shock. And most of the studies that we looked at were for resolving septic shock, although we saw that some patients were prescribed midodrine prior to pressors for shock. It's really important to reassess the etiology of the patient's hypotension. So as the patients leave the ICU and they're still on midodrine, I think continually reassessing not only the need for the midodrine, but why are they still requiring midodrine? the studies really looked at patients who were just on single vasopressors, and we don't know if this midodrine would be helpful for patients on multiple vasopressors. It looked like midodrine did not make much of a difference on ICU readmission. And discharging patients on midodrine, it's not clear what the clinical impact is, but we just saw that many patients do get discharged on midodrine, and this obviously highlights the need for reevaluation on a regular basis that we were just talking about. So there's multiple off-label uses of midodrine in acute care. What we did see was that midodrine 10 milligrams Q8 is a safe and effective starting dose that needs to be adjusted in renal failure. And the most common side effect is asymptomatic bradycardia. The optimal timing for initiation or how best to taper is unclear, but we do need to taper. And adding midodrine to patients with resolving shock may decrease duration of vasopressors as well as ICU length of stay. The carotid stenting patients may be able to avoid ICU admission, and the midodrine may decrease vasopressor use, ICU, and hospital length of stay in patients with post-ischemic myocardial dysfunction. And those patients are not in cardiogenic shock. So in terms of like evaluating the evidence, studies with fixed dose midodrine are limited and their conclusions have been ineffective. So it's unclear as to whether the fact that they designed the studies with the fixed dose midodrine affected their outcomes. So it's hard to really draw any conclusions from that, because the studies that actually had titratable midodrine concluded that it was effective. So that still needs to be sorted out. The dosing interval of midodrine administration may not be adequate, particularly in some of these patient populations that we're looking at. We saw the pharmacokinetics of midodrine, and perhaps some studies with titratable and more frequent dosing are indicated. The duration of prescription in the studies that we looked at varies from 1 dose to 7 days. Some of them were just for 24 hours for 3 doses. I'm wondering if anyone has any ideas of any potential uses outside of the ICU where midodrine may be effective. I can pause there and see if there are any thoughts about that. I mean, I have a thought. I think that, the patient who wants to limit care, who is hospitalized and is still looking, oh, Dan, I think you're raising your hand.
Yeah, I mean, I have a comment, but I might take us in a slightly different direction, so I don't want to derail you, but I think you've done a brilliant review of the evidence for midodrine, and I think what it says to me at this point is we still haven't really met the standard for demonstrating that midodrine is effective as a therapy in the early resuscitation period for sepsis, which is concerning to me because I often find that that's a situation where we're using midodrine. And if you asked me if I was a national guideline member or something like that, and responsible for establishing the standards around this, I would probably only offer midodrine as a second line treatment in the early resuscitation of sepsis. So somebody who says, I'm DNR, DNI, I really don't want to go to the ICU, I really don't want a central line. Okay, midodrine is a good option for that patient because we're not going to give them the standard of care. But it makes me very nervous to think about giving midodrine in place of pressors and ICU care for patients who really would otherwise be accepting of that care, because those are the established standards. And I think there's evidence for those standards, and there's also a medical legal risk that we're taking for that in that situation when we don't offer the standard of care. And the other thing that I would just comment about midodrine is I think that there's a tendency to link midodrine use with ICU. And to me, I think those two things are actually very different. I mean, midodrine is a medication we can offer, and it's part of the care that could be provided outside of an ICU. But there are many things that go into moving a patient to the ICU that are unrelated to midodrine, such as the nursing assessment, the frequency of fluid administration, the kind of hemodynamic monitoring you can do. And often what happens is we say, well, we're going to put this person on midodrine, so we're not going to put them in the ICU because it's an oral medication. And I think we need to really uncouple those two decisions in our minds, because I think they are very different. So I apologize for interjecting that, Angie, but I appreciate any comments you have about it. And thank you.
Yeah, I mean, I definitely agree. It's funny because when I first did this presentation like 3 years ago, I had more ICU-based studies, and they're all really terrible studies, and they don't really help us very much in terms of like the way that they were designed, and the points that I just made about dosing and having it being fixed or titratable, and is it the right frequency, and when's the right time to initiate it. And can we initiate it prior to vasopressors? And I don't disagree with anything that you said, Dan. I think that, if a patient is hypotensive and newly requiring any kind of pressor, whether it's oral or IV, the level of care definitely needs to be escalated in some way, shape, or form. And they often aren't quite as simple. The patient that I talked about with the acute pyelonephritis, I think she would have been a perfect patient to trial a little bit of midodrine, because her lactate wasn't that high, her respiratory rate was normal, she was awake, alert, and oriented, but she needed norepi for a little while. And but she probably still needed to be monitored in the ICU, and probably couldn't just go to the floor like that. She could have been like a quick transition. And I don't know if she would have been a candidate for the intermediate care unit. But I would be a big proponent. I mean, my idea of the patient who would be a good candidate, Dan, you just said exactly what I was going to say. It was like the person who kind of wants to limit care, who doesn't want a central line, who doesn't want to go to the ICU. Those patients may be good candidates for trials of midodrine. And while you're resuscitating fluid, we know that the peak effect starts at 1 hour to 2 hours. So you have a pretty good idea of what you're looking for and when you can reassess, and probably how long you can wait, and if you can wait that long.
Angie, what I would love is if hospital medicine and critical care could collaborate on a trial to look at use of midodrine in the early resuscitation period for sepsis. I think that's what really needs to happen, is somebody needs to do that study. And it's such a pressing issue for both of our services right now, and we really need to work together on that. That'd be fantastic.
Yeah, I think that's what I was hoping would come out of this, is kind of, the general, it's really disappointing, right, to come to a grand rounds and hoping to have an answer and not having an answer. But I think that's what this is showing us, is that there's no real good evidence, and there's certainly opportunity to study this. And I think, yeah, I agree, Dan, that doing something collaboratively would be optimal. And John Zuckerman has a comment about mitigating the hypotensive effects of other medications like Parkinson's treatment with midodrine. I was also curious how many patients, how many providers were that were prescribing midodrine as hospitalists. If you were discharging them on it, were you providing tapering instructions for it?
Hey, Angie, I'll speak up now. It's Leslie. I agree with Dan that was an awesome presentation, because I really wanted this. I needed this to kind of know where we were in terms of evidence for midodrine. Well, to your last question, I don't prescribe it on discharge. I would always want to get that off. To another point, I'm wondering, given you've shown us really well that there is no evidence for midodrine, and to me in any of these settings, why has it become so common practice? Because I'm normally associate critical care medicine really using highly based, evidence-based medicine. So why is it being used so freely? And then I want to also recognize that the side effects we've talked about are mostly bradycardia, but I've seen a lot of patients on their tamsulosin plus their midodrine, plus they have urinary retention. I mean, there's a lot of things down the line. You think of delirium from that, you think of unnecessary catheters being placed, you think of colities and all of that. We're not sure if there's even a lot of harm from using midodrine.
Yeah, I think, obviously, like with the information that we have from some of the larger, like they're all retrospective, but I think that those are helpful for adverse effects. And, the lowest mean heart rate, I think in those studies was about 33 to 35. It was asymptomatic, and it makes sense to me that it was that parasympathetic reflex with the hypertension, but that actually selects out some patients that you can give it to. We've discontinued midodrine due to bradycardia, even if it was asymptomatic. If they're getting down into the 30s, obviously, that's a little too low for some patients. The urinary retention, I was talking to Meredith Beauregard about the presentation. She was like, oh, I bet like a lot of my patients have urinary retention from midodrine. So probably she'll start paying more attention to that, which obviously leads to other problems, like you pointed out, Leslie, down the road. And, we've used it a lot in the neuro ICU. Those of you who have, if you're a resident and have rotated with us in the subarachnoid hemorrhage population, when they end up on long-term vasopressors for vasospasm, and we've transitioned them to midodrine. And I actually, we've had a couple of cases back to back where we've done that, and the vasospasms seem to get worse. And I wonder if it does cross the blood-brain barrier in patients that have, that it's probably not intact and that have been brain injured. And I would love to measure the desglomidodrine levels in their cerebrospinal fluid and see if it's in there or not. So I think that there's a lot to learn about midodrine. I think it could have a lot of really good, it could do a lot of really good things for our patients, but we just don't know a lot about it yet. I'm going through the chat box. So John Gilboy said, to Dr. Meyer's point, I think that midodrine is being used to stopgap to ease institutional discomfort with peripheral pressors and logistical challenges in the ICU and INCs. And Ross said, I don't know if I have to reply to that, John, if you want me to comment on that. And then Ross, the discharges I've done on midodrine have been to mitigate the effects of other hemodynamic, other medications or hemodialysis, I think is what the HD is. So no tapering. I guess I worry a little bit about patients going home if midodrine's a new prescription with a supine hypertension. So obviously each patient is individual, but just keeping that supine hypertension in mind on that graph that we looked at earlier, where the 20 milligrams of midodrine, a lot of those patients, these were patients with orthostatic hypotension, their supine blood pressure got to 200 systolically, which could be a problem, for some patients with either with heart failure or with any other kind of adverse effects from hypertension with intracerebral hemorrhage, et cetera. And then Dan commented on Leslie's comment. I think we should be tapering this medication steadily after ICU discharge with steroids, along with steroids prior to discharge. Yeah, I definitely, I don't know how confusing that chart was that I put together with the vital signs of the PEA arrest lady, but that midodrine probably should have been tapered down pretty rapidly. And as you go through the notes on that review, there are multiple comments of wean midodrine, 30 milligrams Q8 wean as able, and it kind of gets carried forward, but nothing's ever done about it, and it probably should have been weaned. And there were some comments from the cardiology team about weaning it. And then there's a comment here from Nellie. I wonder if there could be a tapering guideline for midodrine similar to our clonidine taper out of the ICU. I think that there's discomfort in tapering it, so it is left on for too long. Yeah, so that's actually a good question. And I don't know if any of our pharmacists are online, but if they're not on, oh, Chelsea is on actually. I think that's actually a really good idea, Nellie, and it looks like Dan agrees with me. And we do have some cost. I think, Mike, you had asked about the cost. So our inpatient acquisition cost is approximately $1 for 10 milligram tablet. And then Chelsea commented, for cost, patient charge in the inpatient setting is $7 for a 10 milligram tablet. Okay, so $7 for a 10 milligram, pretty cheap. Well, it's almost 9 o'clock. If there are any more comments or questions, feel free to contact me. I think most people know how to get in touch with me. I'll put my email in the chat box, and I hope that this leads to some further discussions. I can bring it back to my group in critical care about potential collaboration for research, which I think is probably the best thing that could come out of here, aside from, you know, us continuing to think about weaning midodrine and discharging patients not on midodrine. Thanks so much for having me.
Angie, thank you so much. That was a great review. And it's obviously from the chat and the discussion, something that's very topical for us, and we should probably be delving into more. So kudos to Meredith Beauregard too for suggesting this topic. I think it's a great idea. So thanks again.
Great, thank you. Have a good day, everyone.
Bye now.